Dr. First of all, I'd like to thank Professor um, uh, for inviting me for this meeting. And unfortunately, we were supposed to be in Egypt. I was looking forward to it, but because of Corona, it is pleasure to share um, through video. I'm Dr. Verma, consultant microbiologist. I mainly from King's College Hospital, and I mainly do the infectious diseases for transplant patient and patient with liver diseases in pediatric and adult size. First talk is today a multi-drug resistant organism in the era of antibiotic stewardship. In the next 25 minutes, I would like to discuss the MDRO in the healthcare setting, risk factors and contributing factors for MDRO. What are the emerging new superbugs in this era and impact on patients? And what is the role of medical community in combating MDRO? So first of all, we need to know what is multi-drug resistant. And according to CDC, resistance is to all antibiotic in at least for two of the three following classes, which is fluoroquinolines and beta-lactams or aminoglycosides. So we are getting more and more pan resistance, which means they're resistant to all licensed, routinely available antibacterial for clinical use. It is very important for us to understand how these bacteria are acquiring the resistance, and they are evolved over the year to combat effect of new antibiotics. There are so many mechanisms involved here. Either they get a mutation or alteration in the cell wall permeability, which prevent the active efflux of these antibiotics. And the most important mechanism which is evolved over the years is the protection of inactivating enzymes. And most important among these enzymes are the beta-lactamases, which is the major mechanism for bacterial resistance now. So these beta-lactamases, there are more than 300 enzymes, and among these, this CTXM, which is classical extended spectrum beta-lactamases, these are the one which are becoming quite highly prevalent in the current era, and although they could be chromosomal induced, and this is one of the popular mechanisms for becoming resistant in most of the bacteria. And the other important enzyme which I like to mention is carbaphenamases, and these are the enzyme which are becoming carry the resistance for carbapenem antibiotics and are becoming most prevalent now in the current area. So the key multi-drug resistant organism which I'm going to discuss, I will use these abbreviations: MRSA, which stands for methicillin resistant Staphylococcus aureus, VRE, vancomycin resistant Enterococcus faecalis, ESBL, extended spectrum beta-lactamase Enterobacteriaceae, and CRE means carbapenem resistant Enterobacteriaceae, and non-lactose fermentum, which are Pseudomonas acinetobacter and Pseudomonas. What are the contributing factors for these MDRO? Most important in the current era is overuse of antibiotic. For example, global overuse of estimated rate of antibiotic is 40 to 70%. And the example I like to give you, in US, 80 million of antibiotic prescription are used to treat the viral infection in outpatient. Whereas 90% antibiotics, they are used for livestock and fish farming. Example is over 60,000 tons per year used worldwide, and MDRO which are developed from in animals, and they are then transmitted to human beings. And the other most important contributing factor is inadequate infection control practices, which I will mention later in the slide. The most important gram-positive MDRO infections are MRSA and VRE. They are highly colonized. MRSA is particularly colonized in the community and as well as in the hospital, whereas VRE is mainly the organism which is acquired in the hospital. The infection rate can vary from patient types, as for example, the VRE is highly prevalent in the liver transplant population or patient with the GI diseases. They are associated with very high mortality, and the risk factor for infection usually involved the previous colonization, invasive devices for a long time, and VRE, the risk factor is liver transplant patient itself. So the treatment for these MDRO is there are still some of the antibiotic in the pipeline which we can use. For choice for MRSA is vancomycin. We can only treat vancomycin if the MIC of MRSA is less than 2. And the other choices are linezolid or daptomycin. Whereas VRE, we can only use the linezolid, which is the first line antibiotic for treating the vancomycin resistant enterococcus. But daptomycin, we can have the second choice, but the efficacy for VRE treatment is not very reliable. These organisms, if they become resistant to linezolid, then we have not much choice to treat after that. So can we decolonize these organisms that can reduce the rate of infection? MRSA, there are set protocol. We can decolonize by using chlorhexidine body wash or nasal miprocin application for 5 days. Whereas VRE, there is no method to decolonization. And now, among the gram-negative MDRO, non-lactose fermenter. So you have to understand that a lot non-lactose fermenter, they mainly are like Pseudomonas, Acinetobacter, Serratia, Stenotrophomonas, and Burkholderia. And most of these are highly prevalent in the environment and mainly acquired in the patient who has long ICU stays. They could be associated with very high mortality, and some of the organisms, they are highly prevalent in cystic fibrosis patient. So this is the slide which shows the increasing resistance to carbapenem in the Europe for Pseudomonas, and we probably have the similar picture from other part of the world. Now, the two most important gram-negative MDRO lactose fermenter, the ESBLE and the CRE. So ESBLE stands for extended spectrum beta-lactam Enterobacteriaceae. These are rising in the community and globally, and the prevalence rate is up to 10%. Increasingly, they are colonized, and colonization rate varies from 10 to 63%. They're highly prevalent in the community, and UTI is the most common infection. Patient in the hospital setting, they get the bacteremia. So if we look at the prevalence of these in pediatric patients, they are highly prevalent in the pediatric patient, up to 59% colonization rate, whereas in neonates, they are the highest. In terms of type of coliforms, Klebsiella and pneumoniae is the highest prevalent, and in older children, it is the E. coli. So what type of patient do get more colonization? They are typical patients who are in medical or ICUs or surgical units, and in neonates it's a similar picture. Mainly the ICU patient, they are highly colonized, or patient coming to emergency, or in neonates, they have the high prevalence of these organisms. Now, if we look at the global trend of the human carriers of ESBLs, Southeast Asia, they have the red line, which shows the highest prevalence, and in Europe, they are the lowest. number, which means that they are less than 100 per thousand population, or in other countries they are variable prevalence in different countries. So now this is the one of the emerging new superbugs which I like to highlight in the medical community, and it's called CRE. This is the most worrying emerging superbug. In the CDC, it was declared as the alarming bug in 2013. It is like a ticking time bomb for the world. We call it a terminator because this is highly resistant, and the patient, if they get infected, could be associated with very high mortality. So what is this CRE? It's called carbapenem-resistant Enterobacteriaceae. CRE is not only resistant to last resort antibiotic, carbapenem, but also to most of other antibiotics. As you know, these are the carbapenems are these four most important: meropenem, ertapenem, imipenem, and doripenem. We mostly use meropenem and ertapenem. So carbapenem is a group of antibiotics which are active against Enterobacteriaceae and Pseudomonas anaerobes and ESBL, and sometimes moderate activity to the Streptococci and Enterococci. And after the carbapenem, we have no other antibiotic to treat gram-negative organisms. So Enterobacteriaceae, just to understand, because we have the name CRE, ESBL, these are the family of bacteria, mainly these two organisms, E. coli and Klebsiella, which are the normal flora in the gut of every human being. And these are the particularly carrying the resistance gene and becoming resistant and can harbor these CRE and ESBL in the normal healthy people. And these are the gut flora and can cause various variety of infections. Now, this CRE, why they are so dangerous or important, they are harboring the enzyme which is called type of beta-lactamase carbapenemases. This is the most versatile beta-lactamase because it is carried on a mobile gene, which we call it as a plasmid, and these plasmid are mobile, which not only in the positive in the organism lactose fermenter coliforms, but also in the non-lactose fermenting bacteria like Serratia, Pseudomonas, and Citrobacter, so that they can transfer from one bacteria to another. So that's why they are the most important. Based on the mechanism of resistance, they are also called CPE, which means carbapenemase producing Enterobacteriaceae. So the classification of these carbapenemases is very important because we need to know the name, what types are they, because they are important from the treatment point of view. The class A, the KPC, the metallobeta-lactamase, IMP, WIM, and NDM, and OXA48. These are the highly prevalent all over the world compared to other names of the CRE. So the resistance gene is a major concern worldwide and is spreading faster and now prevalent worldwide. If you see the first gene, it appeared in 1996. Nobody was aware of during those days. In 2003, the first gene appeared in KPC in New York City. And then KPC spread all over the European countries. And followed by that, we had the NDM, the first case in Sweden, which was traveling from Delhi to Sweden for the treatment. So resistance is becoming a global problem because of international travel and medical tourism and overuse of antibiotics and silent dissemination. The CRE is in transplant patient recipient, and hematology patient is an ever-growing challenge because this is an independent risk factor for solid organ transplant recipient. and some centers, entire burden of CRE reside in the transplant patient. If you see here, the prevalence is quite high in the transplant patient and hematology malignancy patient, and they are associated with very high mortality. So CPE, we have our experience in King's College Hospital, especially in our liver transplant recipients. If you see in pediatric, we have 31% prevalence rate in 2013 when we were not doing screening. In 2018, now we have 6%, whereas in adult transplant patient, it varies from now same 5 to 20%. Infection rate is low, and especially the mortality rate is also low. The therapeutic option for treat CRE is very limited. There is the only drug available with sensitivity is colistin. However, this drug has a number of drawbacks. It has got uncertain pharmacokinetics and pharmacodynamics. It is highly nephrotoxic, neurotoxic, and single therapy is not effective. Other options are tigecycline and fosfomycin, but they are used as a salvage therapy because of low efficacy for treating these infections. Now, combination therapy is the best way to treat these infections. The benefit of that is that they are associated with mortality benefit over monotherapy, and some of the combination have synergistic effect and high rate of microbiological cure. So the combination we have used and effective are colistin plus rifampicin. You can use colistin fosfomycin, and there are various other combinations, but these has to be based on your sensitivity test. So the last resort antibiotic, the colistin, it is becoming increasingly resistant now. The story of antibiotic always is that sooner or later, with the more use, they will become resistant. If you see, this is the slide which depicts the scary trend of becoming resistant at one point. So risk factor for infection with MDRO, healthy people and in the community or in healthcare setting, we can all get colonized with all these MDRO, but not necessarily we can get infection. Only patients who are at high risk of getting infections are with patients with chronic or severe illnesses, long hospital stay, immune suppression, or TPN dependent or with invasive devices. Now, this CRE is also found scarily in water, sink, tap, sensor. So you can guess that can spread so easily. And improper cleaning of equipment, endoscopes, and ultrasound machine. And these spread can stay most of the time unrecognized. Now, survival of pathogens on surface, this just show that how these MDRO can survive for a long time on the surfaces. Now, impact of MDRO, they are associated with high risk of mortality, longer hospital stay, and high medical cost. This slide just shows that there is an extreme variability or disparity in prevalence of MDRO, and they are associated with very high mortality in Africa and if you see South Asia. And currently, drug-resistant infection causes around 700,000 deaths worldwide. And if you see the mortality by 2050 will be higher than cancer with the MDRO. So MDRO, if you look at cost-wise, this is just the CDC slide which shows the cost. It costs healthcare in billions of dollars and euros. What can we do to prevent or reduce the threat of this MDRO? Prevent the spread and strict antimicrobial stewardship and development of newer antimicrobials. And it has to be national level approach. To prevention of the spread, the most important, what works best is active surveillance. Not necessarily we have to do the surveillance for most of the MDRO, but it does work very well for some of the organisms like CRE and MRSA. And we have to implement effective infection control measure which included the list of following. Antibiotic stewardship, it is a program that encourages judicious use of antibiotics. Team of infection experts, clinician, and pharmacists should be involved as stewardship. It strives to find the tune antibiotic treatment in regards to efficacy, toxicity, cost, and duration. So this is the kind of antifungal stewardship program you have to develop. Is means that you have to put the guidelines, education of the staff is very important, which can be done through various ways. And there is a World Antimicrobial Awareness Week. And it is important to monitor the practice by doing the antimicrobial audits and looking at the impact on cost, bacterial resistant, and improvement of patient care in your hospital. So development of new antibiotic, because we are getting the MDRO where there's no antibiotic to treat. Can we develop the new antibiotics in the following years? The answer is no. There are only 7 antibiotics in the clinical development for gram-negative organism, but some of them, they are not even effective, especially to metallo-beta-lactamase. So this is the WHO, which publishes the list of bacteria, showing the urgency of the development of antibiotic against certain organisms that include the Acinetobacter, Pseudomonas, and Enterobacteriaceae, and the priority for another bacteria is shown in the 2 and priority 3. So this is again, sorry, the repeat of the slide. These antibiotics we can develop, but they will again get the resistance at some point. So we are reaching in the era where there will be our no antibiotic. Our health services will be like 19th century. Even the routine surgery can become deadly. It will be down to luck when infection with pain-resistant bacteria. Worst case scenario would be like world in 1920s and 1930s. And this is the slide just to show when there was no medicines, the sick patient with TB were sent in the open air. So take-home message is that MDRO, especially CRE, are a growing challenging area of healthcare, and novel antibiotics are unlikely, at least not in the near future. Everybody is responsible in their own area of work within the mandates to implement antibiotic stewardship, effective infection control practices, and improvement and better integration of surveillance system. And thank you.